Today, we're going to completely demystify the incredible complexities of systemic lupus erythematosus. Often just called lupus, SLE is this absolutely fascinating multi-system autoimmune disease that essentially turns the body's own defense mechanisms into a relentless attacker. Now, I know it can seem super overwhelming when you're staring at a textbook, but don't worry, we're going to break it all down visually today. Okay, let's just dive right in with a pretty staggering statistic. This rare disease predominantly strikes women. We're talking about a massive 9-to-1 female-to-male ratio. And while it only affects a tiny fraction of a percent of the global population, when it does strike, it usually hits patients right in the prime of their lives, typically between the ages of 20 and 30. So, to make this whole thing easy to understand, we are going to follow a really clear roadmap. We'll cover who gets lupus, the pathophysiological cascade, the systemic clinical manifestations, and we'll wrap up with patient prognosis. Section 1. Who gets lupus? The complex web of triggers. Right, so the exact singular cause of lupus? Well, it's actually unknown, but we do know it's a dangerous mix of two primary categories. On one side, we have a genetic predisposition. These are factors like the presence of HLA-DR2 and DR3 genes, genetic deficiencies in classical complement pathway proteins, think C1q, C2, and C4, and hormonal factors, specifically hyperestrogenic states from things like oral contraceptives or endometriosis. But here's the thing, just having the genes isn't always enough. These genetic susceptibilities really have to interact with environmental triggers. We're talking about cigarette smoking, silica exposure, specific drugs like procainamide, and very notably, UV light. Section 2, the pathophysiological cascade. Zooming in to the cellular level. It begins right here, when a genetically susceptible person encounters one of those environmental triggers we just talked about, like UV radiation from sunlight hitting the skin. This is essentially the match that lights the fire. This radiation actually causes apoptosis, programmed cell death. When the cell breaks apart, it literally spills the contents of its nucleus out into the open. We're talking about DNA, histones, and other nuclear proteins that are supposed to be securely locked away inside the cell. Suddenly, the immune system sees these familiar parts as completely foreign invaders. Now, in a totally healthy body, these cellular remnants are quickly and quietly cleared away by the immune system. It's like a cellular cleanup crew. But in a lupus patient, there is a fundamental defect in this process. This much less effective clearance leads to a massive, chaotic buildup of these nuclear antigens just floating around. Because these antigens are just sitting there, the immune system inappropriately mounts a huge attack, producing autoantibodies against them. These then bind together to form antigen-antibody complexes. These immune complexes enter the bloodstream, where they basically travel like tiny inflammatory grenades until they deposit themselves into target organs and tissues, places like the kidneys, the skin, the joints, and the heart. And this right here, this triggers a classic type 3 hypersensitivity reaction. It's actually the most common pathomechanism in SLE. Those trapped immune complexes activate the complement system, unleashing this violent enzyme cascade that causes severe local inflammatory tissue damage right where they landed. The body is essentially caught in the crossfire of its very own immune response. Section 3, systemic clinical manifestations. Let's zoom back out to the whole body.
Because the immune complexes can deposit virtually anywhere with microvasculature, we see wildly contrasting symptoms depending entirely on the organ that gets hit. Take the cardiovascular system, for example. The most common manifestation is pericarditis, but we also see a greatly increased risk of accelerated atherosclerosis and even Lippmann-Sachs endocarditis, which is this accumulation of sterile vegetations right on the heart valves. Now contrast that with the neurological side. Patients can suffer from extreme chronic fatigue, visual hallucinations, chorea, or even organic psychosis.
So the crucial takeaway here is that virtually no system is spared. Hemological destruction, driven by a type 2 hypersensitivity reaction, where antibodies attack red blood cells directly, causes hemolytic anemia and severe lymphopenia. And actually, monitoring that lymphopenia is a really great guide to tracking the disease's overall activity. Meanwhile, the gastrointestinal tract can suffer from painless or painful mouth ulcers or incredibly dangerous conditions like mesenteric vasculitis, which can quickly lead to bowel infarction. We also absolutely have to highlight an important clinical distinction: pediatric or juvenile onset SLE. This presents a far more aggressive clinical picture than adult onset. Kids experience significantly higher rates of severe renal disease, that classic malar rash, cutaneous vasculitis, and severe neuropsychiatric manifestations compared to adults.
Section 4, Prognosis and Patient Outcomes, the Lifelong Timeline.
So, what does all of this mean for the patient's future? Well, the good news is that modern medicine has improved outcomes dramatically. The 10-year survival rate is now roughly 90%, but the risks they face shift pretty drastically over time. In early disease, acute mortality risks are driven by high disease activity causing active organ failure, particularly in the kidneys or the nervous system, as well as infections related to their immunosuppressive therapy. But as we move into late disease, chronic damage really takes over. Cardiovascular disease, specifically complications from accelerated atherosclerosis and coronary artery disease, becomes the leading cause of death, right alongside end-stage renal disease and the adverse cumulative effects of long-term medication. Because fatal damage to the kidneys is such a massive, ever-present risk throughout the entire timeline of the patient's life, your most critical clinical pearl today is to consistently perform regular urinalysis on your SLE patients. Catching renal disease early and intervening can absolutely prevent progression to severe disease and ultimately save their life. Well, we hope this structured breakdown made the complex mechanisms and manifestations of systemic lupus erythematosus a whole lot easier to grasp. Thank you so much for watching, and remember to subscribe to MedMedicine for more visual explainers just like this one. I'll leave you with this final thought to ponder. If our own immune systems can become so perfectly orchestrated to cause such widespread systemic damage, what incredible things could happen when we finally figure out how to perfectly reprogram them? See you next time!